product or perspective that a vendor had. In the past, when I trained in the 1990s, you're young, so you probably have never done an open perspective. I did in my chief presidency, I used like 125 open perspectives. And we did a lot of guessing. And you would say, I'm a reconstructive drawings, and I hate anything that is taking out things and put things together and to fix them. So over the life, since that period of time, the Da Vinci robot has made this surgery so incredibly precise. You see, what we used to guess open were the nerves and control erections, or we guess on that. Sometimes we saw the majority of the time we didn't. With a robot, Da Vinci robot, you can see it at least in 10 times in HD, precisely where they are. So the surgery is very precise. It's essentially bloodless, right? Today, requiring a transfusion. In the past, we used to keep a catheter for 10 days, anywhere between 3 to 7 days in the hospital. Now it's like an overnight stay. The catheter is anywhere between 4 and 7 days, depending on the practice. And the results are essentially better, if not same or better. But they'll go back to normal activities, dramatically improve. Now, also the other treatment option with curative intent is radiation therapy that can be delivered in a number of ways. Seeds, external beams, from IMRT, it's short for a very complicated terminology. And in the past, when I trained, essentially the technology was such they pointed a radiation beam in the general direction of the prostate, so it affected the bladder, rectum, and so on. These days it's incredibly precise, so it tends to just be directed at the prostate, most of the time it spares the bladder, the rectum. So in the right stage, it's an excellent choice too, if the patient, especially medically, cannot tolerate a right perspective operation. There are other modalities, cryotherapy, ultrasound, and so on, that proton therapy, that also are in the market, but they have not had the same follow-up or the maturity of the studies as the radical prostatectomies, especially robotic and the radiation. So those are the two things that you can consider. We have, by the way, here in the Valley, we have all the options available. And at DHL, we exist with the intention that a patient should only leave the Valley to get their care by choice, not because we don't have to make. So that's what you do.
So we definitely made strides, and there's a lot of options that are out there. So I'm so happy that we're having events like this, and it's great to see a room full of people that are going to get PSA testing today. So Dr. Phil, for the men that maybe did not come forward, what sort of advice do you have for them if they're maybe hesitant or a little fearful about getting that screening for prostate cancer?
Yeah, of course. Before I answer that, I kind of want to piggyback on Mrs. Garcia's statement. So there are a lot of patient education materials out there. The one that I like to use, it's made by the National Cancer Society, so NCCN. So if you Google, it Google's, a lot of patients just start to Google these days. So if you go and Google NCCN and just type in kind of cancer, so in this case it's going to be prostate cancer, and there's a whole PDF just dedicated for patient learning. So it's really good, useful tool. It has a list of questions that the patient should ask their doctor. It's really insightful tool. And also kind of follow up on Dr. Ruiz's statement as well. So there are different ways to treat the prostate cancer. We can surgically remove it, it's radiation, but also active surveillance and watchful waiting are also another two options. So active surveillance, it's a modality where we know you have prostate cancer, just like Dr. Ruiz suggested, it's for localized prostate cancer with a low risk. To those individuals, active surveillance means that we know you have cancer, we're just going to keep an eye on it, do biopsies every once or twice a year, get MRIs just for the prostate, depending on the provider. And then the goal of the active surveillance is to delay the side effects of the treatments without really missing the opportunity to cure it. So just want to put it out there. I counsel my patients, yes, you have cancer, but you have a low risk, so we don't have to treat it now, right now. We can just keep an eye on it. So that's always a good option for guideline. And what was your question again?
What do you want to tell them that maybe you're a little hesitant about getting the screening?
Yeah, so as everyone pointed out, prostate cancer is silent, right? Meaning majority of the patients don't really have any symptoms. So there are a lot of patients that tell me, hey doc, I don't have any symptoms. I know my PSA is high, but do I really have prostate cancer? Then I tell them, yes, it's good that you don't have symptoms. But depending, based on your PSA, your family history, I think you may have prostate cancer. And it's the most common cancer diagnosed in men, so that we should proceed to the next step, which typically is the MRI and then biopsy.
Okay. So, Mayor, we heard about the